What is up? Hello and welcome to episode 122 of Chairside Live. We've got a good episode for you today. We've got part 3 of my interview with Dr. Paul Homoly, where Paul's going to actually go through a real example of how he would consult with a patient who is seeking treatment and now is going to be presented with a treatment plan, and we're going to walk through that as kind of an introduction to his Yes Online. Paul does a great job with his programs. One of the first ones I saw regarding case acceptance was, isn't it great when patients say yes? And I think we can all agree that yes is the correct answer to that. In the case of the week this week, we've got an interesting one where something actually went a little haywire here at the lab. So I wanted to get a chance to at least expose a few of our spots as well, because something went wrong here. It got caught before it went out to the door, fortunately, but it's kind of a funny story to see. But we're going to start off today's show with a viewer mail. This is from Dr. Tom Kirsten. Tom was nice enough to write into us, and he writes, Mike, I don't recall you discussing the phenomena of the possibility and how to manage usually a second molar case when it's the centric stop. When this is eliminated during the preparation, the condyle seats further up in the fossa, and there's a permanent change in the occlusion. Sometimes this is noticeable at first, and sometimes not. It may not be noticed even at the impression or during the temporary fabrication, or yet it may be, and there could be a hole in the temporary. It may not be observed until the patient has worn through the proper vertical of the temp or knocked the temp off and returned for the crown cement. And if we could manage this proactively, it would be fantastic. If they've knocked the temp off, even though the original vertical is maintained, there may be unrecoverable loss of vertical dimension due to super-eruption. Do we live with the new vertical? The new crown established at the old dimension will now feel high to the patient. I thought it might make a great discussion topic for us. Sincerely, Tom. Tom, I was hoping you would have asked something slightly less controversial, like about the shooting in Ferguson or whether or not there is a God. But if we're really going to go controversial, this kind of gets right to the heart of it, this simple question of what to do when preparing a second molar, because really the main two approaches that we're going to see, one is going to fall into the CR camp, and one is going to fall into the neuromuscular camp. You also asked about a screening, a way to know you're going to be dealing with this. Well, certainly the first clue is that you're prepping a second molar, obviously, and that should, first of all, set the hairs on the back of your neck standing up a little bit. And that's true whether or not it's just the first molar or you're prepping the first and second molar or maybe that whole quadrant. We always want to be able to take that into consideration when that second molar is being prepped. The simplest way, there's certainly a lot of more complicated ways to do it, which you'll find taught at places like Pankey and like Spear and with John Coyce. But I think you're looking for a more kind of simple approach. And certainly what those people do at those institutes is far beyond what I'm capable of doing as an average dentist. I just kind of try to focus on what's happening when we're treating that particular individual tooth in the middle of a busy day, prepping a second molar. And so the place I always start is with a leaf gauge. You can get these from Great Lakes Orthodontics. And each of the 8 little leaves that you see here, each 8 of them, I should say, add up to a millimeter. So each one's about 125 microns thick. Humans can feel anything 30 microns, 12 microns between their teeth. Some people even say less than 10 microns. So basically what we're doing is starting with just guessing with the number of leaves that we put together and put it between the anterior teeth and have the patient bite together, and they won't feel anything on their posterior teeth. Depending on how deep the overbite is, you may have to use more or less of these. And then we simply remove a leaf at a time and keep checking. You can check with shim stock on the second molar or like 12 micron articulating paper back there. You don't want to go with a really thick articulating paper. Asking the patient when their tooth first hits, can be somewhat indicative, but it's a little better to be able to go in there with shim stock and know for yourself when that first tooth touches, because sometimes on a deep overbite, it's difficult for them to tell. And you keep removing 125 microns at a time till they bite down and you have that contact. And a lot of times it will, in fact, be on the second molar. Now, depending on how many leaves you have, if you're down to 2 leaves at that point, we're talking about maybe a 250 micron discrepancy. If you're in the CR camp, this is kind of the CR approach to that. And so this would make it a safe case to treat. If you had half the leaves in there and now we have that second molar primary contact. That's going to be more difficult. That screams the one single unit crown that you'd want to send perhaps to a prosthodontist would be the one where half the leaves were there and they were touching. So if you're going to look at how the traditional kind of CR approach, at least the way that I came up learning this approach, is that you can either adjust that if you feel that there's a slide, because typically that second molar hits and then we have that slide, or what CR people call kind of that long centric. Some will adjust it right then to get rid of that interference. Some will just prep it, but they'll use a depth cutter. And so, for example, on a second molar, they'll maybe do a 2 millimeter depth cut on the occlusal surface and the cusp tips, and they'll reduce 2 millimeters on the occlusal surface of that second molar, have the patient close together. And now they'll take one of those reduction rings that's on a stick, that come in a 1 millimeter, 1.5, and 2 millimeter. And they know they've reduced 2 millimeters with the depth cutter. And all of a sudden, when they go to do it with the reduction ring, you can't even fit the 1.5 in there because, yes, the condyle has in fact seated as you referred to. Now, in the CR camp, a lot of people are okay with that. They want that condyle to be in that more superior position. So if the 1.5 won't slide through there, they'll go and do more reduction until the 2 millimeter reduction ring will slide through, and they're going to restore the crown at that point. And so they are, in fact, going to let that condyle seat more and restore at that point. The neuromuscular camp feels a little bit different about this. They feel that that second molar is that posterior occlusal stop, and it's holding it where it's supposed to be, and so they want to maintain that vertical dimension. So to do it that way, I would take a full arch bite registration with a very stiff bite registration material, specifically Luxabite. It's the only bite registration material that is that hard. And so we're going to take this, full mouth bite registration before we prepare, and it's going to be at the vertical dimension with that second molar in contact, acting as the stop. And so then when we prep that second molar and we're checking the reduction, that bite registration is going to go back into place again, so we know we're checking it at the dimension where we want it. And then we're going to I will send full models with that bite registration to the lab and take full upper lower impressions as well for prepping that second molar, send it to the lab and have them use that bite registration that was taken while that second molar with its original architecture was still in place, and have them restore to that size if you want to maintain the vertical you had before. If you're prepping the first and second molar, you would prep the first molar first, and when that was done, you could do a Luxabite bite, again with the second molar holding you at the proper vertical, and then prep the second molar, and when you take the bite on the second molar, have the bite registration on the first, which is holding you at that original vertical dimension. So it kind of all depends which side of the coin you kind of fall on. If you're more the neuromuscular, let's maintain this, we need to maintain it where it originally was. We're certainly going to take a pre-op impression of that second molar before we prepare it. And if we liked where it was, that temporary, again, made out of a hard bisacryl material, and we want to shorten the time probably between prep and seat for that patient. We don't want them chewing through, as you mentioned, through that hard bisacryl material, that temporary. They can still do that, and so we want to make sure we get them back as soon as possible. You can make a good argument for a chairside crown with, say, a CEREC unit, being able to make it same day with a permanent restoration and not have them wear a temporary at all. Or if you fall on the other side of kind of the CR people where you're going to prep it, know you're going to probably lose some of the reduction. If you don't, great, just restore it there. But if you've done a 2 millimeter depth cut, now you'll have 1.4 and can't get that 1.5 and do more reduction in order to make room for that. You can do that as well, knowing that the condyle has sat a little more superior in the fossa, but that's your goal anyway for reestablishing kind of CR by doing that crown. So again, it's kind of insanely controversial because you could get a bunch of dentists together in a room and argue about this, if not for days, for weeks, or for months. Or actually, if you look back at dentistry, it looks like it's been actually happening for decades. Probably always going to want to do those bite registrations with the patient sitting up, with the patient leaning back. Of course, we now have gravity acting on the mandible, and we're probably not getting a true bite there as well. So for me, it's identifying it with the leaf gauge at the beginning of it, and then based on how many leaves I have there, we might do some adjustments right at the beginning if it seems like we have a lateral slide. But it is something to watch out for, and the more leaves that we see that go in there, the bigger the discrepancy it is, and the bigger the chance that there's going to be an issue and be the one time where a single unit crown can really turn around and kind of bite you in the rear. So this is something that I think is worth going deeper into, whether it's with somebody like John Coyce or Frank Spear or with the Pankey Institute or out at LVI, who deals with a lot of neuromuscular approaches to these types of things. It's certainly worth looking into, and at least having those sirens going off when you're preparing that second molar on a patient, and knowing well enough to say, you know what, this is the one crown that we do that's really tricky, and I see some wear here on your tooth, and I see that it fractured on the one across from it. These are the things. There may be some complications because of this. We may have to reduce more. It could possibly end up needing a root canal. There's just, this is one of those crowns, unlike, say, a first bicuspid, where you are going to talk a little bit more about things that probably could happen. So I know that's not the concise answer you were looking for, because I don't believe there is a concise answer about this, like there is about other things in dentistry. There's controversy everywhere, but this is definitely one of the more controversial topics we could come up with. But hopefully it'll start a dialogue where you can go and look in other places and Google it and go to other courses and hopefully try to find whatever seems to work best for you. My guess is that with like most things in healthcare and dentistry, that certain approaches are right most of the time and other approaches are right most of the time, but no one approach is correct 100% of the time. So thanks for writing in, Tom, and stirring up the hornet's nest and all the hate mail that I'm sure to get. All right, thanks for that, and let's go ahead now and take a look at the case of the week. As you know well on the case of the week, we try to find dentists doing something right at times and other times doing things that need a little bit of improvement. We tend to lean more towards those just because we learn more, I think, from our mistakes than we do from our successes. And every once in a while I get to turn the finger around and point it back at the laboratory. And this is one of those cases. And this is a funny one because it took us a while to kind of figure out what was going on here. This is an impression for a crown on tooth number 3, and like most of the single unit crowns we receive here, it's in a double arch tray, and this is for a Bruxer crown on tooth number 3. And so it was the initial pour of the model, and then it was poured again. So it was poured 2 times, and then it was scanned. And so the scanning procedure, when you send us a conventional impression like this, is we pour up the models, and then essentially what we do is we scan the solid model, and this is going to be the one that we design the crown on, mainly because the contacts, it's so much easier to get accurate contacts when we also scan the solid model. So we scan the solid model, and then we have the pinned model, and we're going to take out the die itself. And this is going to be scanned at a higher resolution for the margins. And so the scan of the margins on the trimmed die gets merged by the software onto the scan of the rest of the prep and the contacts. And so we're going to use a combination of the high resolution scan at the margin and the scan of the solid model, which has better contacts, as you might imagine, on the solid model than we have on this one, because there's a little bit of movement and play in these segments. And so we scan this die as well, the separate trimmed one, and that's going to be at the highest resolution. And that will get superimposed onto this so that we have a die with the best contacts possible and the best margin possible. Then we're going to close this and scan it as well. Oops, I pushed that up from both sides. And that's going to how our virtual articulation is going to be done by scanning these two together like this. And so once that is all in the software, we can then design a crown on here using the margins that are on here, using the occlusion on the virtual articulator, not only go up and down, but do the lateral excursions as well. And out pops out, when we're all done milling, a Bruxer solid zirconia crown. So once the crown is done milling and before staining and glazing, it's tried back onto the model to check for contacts, and it looks pretty decent here. It's checked with some articulating paper for the contacts, and then it's checked on the articulated model to see whether or not the bite is correct. And we've got an issue here as it goes onto this model. We looked at this for a second and said, wait a minute. We put it on here and we go, okay, that looks good. The cusp tips, the buccal cusp tips line up. This is tooth number 3. Here's our occlusal lingual groove, the OL groove coming out to the lingual. But when we take this off and then try it on the pinned model, it looks funny and it looks out of place. And all of a sudden, the buccal cusps are way over to the lingual, and the OL groove is coming out towards the buccal surface of those teeth, and yet it fits on both of these. And at first, the technician thought, well, maybe it was re-prepped. Did the doctor re-prep? What happened here? And it took a while of us looking at this on both of these to try to figure out what was going on, and the technician said, should I finish the crown? And I said, well, let's see if we can't get to the bottom of this. And finally we went in and actually picked up the impression itself. And what ended up happening as we looked at it and figured out what happened is the first time that the model was poured of this 2-step impression, you can kind of tell it's a 2-step impression from the way these 2 layers are separated here. So the yellow was taken first, and then it was relined with the green, so it's really not incorporated. So the first time that the impression was taken and the model was removed, we went back to the dye department, the plaster department, and they said that this had come out and it was sitting on the model itself. And so when the stone was pulled out of here, this came out, and then the technician took it and put it back in again, but jammed it in backwards, so it was rotated. So buccal was now lingual, and lingual was now buccal when it fit back in there, and it was poured up a second time, and that explains the mirror images that we have here. On one of the models, it was put in this way, and on the other model, the wash material came out and was turned around. At least the central groove was still going in the same direction, but somehow this got jammed in here. I wasn't exactly there to see how it got jammed in. Somehow it got jammed in and poured a second time, and that's on us, obviously, and fortunately it was caught before it all happened. But again, it kind of goes to the 2-step impression. So when this came out, you can see that it was a pre-op impression, essentially. There's the tooth before it was prepared. The doctor may or may not have used this for the bisacryl temporary. It doesn't really look like it. Usually once you've done that, you at least see a little air inhibited layer, or you can at least see just some sort of sign that it was made for that. And we know that bisacryl material will keep these 2 polyvinyls from sticking together. But also just, relining this after you've done the prep and putting a little wash material there, these 2 materials aren't going to bond together chemically because they set at different times. Now, don't get me wrong. This is 100% our fault what happened here, and thankfully it never went out the door. And so I don't know how you could put this back in, spun around 180 degrees and think it was correct. But it does kind of point out how these 2 layers don't always fuse together. So fortunately, the technician stopped, and we did not send it out the door with the occlusal lingual groove coming out to the buccal, because I'm sure we would have got a weird phone call from the dentist when he said, well, the crown seems to fit backwards on here, when in reality on the solid model, that's how it should fit. And actually, I don't even know, considering that this little portion has been out now and kind of pushed back in again, I don't think there's any way to get it to really seat completely again. We could probably send the crown to the doctor and say, you know what, try this, see if it fits. If it doesn't fit, take a new impression. We apologize, that kind of thing. But I did want to get a chance to kind of point out one of the goofy things that happens sometimes in the lab. Fortunately, this one got caught before it went out the door. But again, you can see that, had these been taken simultaneously and these 2 impression layers had cured at the same time, we would not have had this issue, and there wouldn't be any chance of that inner layer coming out. So yeah, 100% our fault on this one. But again, it kind of brings up the point and reinforces that taking this impression with these 2 material, the tray material and the wash material simultaneously, nearly always leads to a better impression.
Now, what you're seeing superimposed on the screen is a portion of the Discovery Guide tool. Again, this is the tool. And what the dentist does is fills out across the top the sequence of presentation. Not the sequence of treatment.
Right.
That's the sequence of presentation. We're going to discuss from left to right, just like reading a book, what's important to her first, what's important to her least.
The way we'd fix this tooth is simply remove the darkened enamel from the tooth and replace it with a new enamel-like material. Plus, there's an infection like a boil at the end of your tooth root that we'll take care of too. Of course, all of the recommendations for treatment I'm making are dependent on your budget. I understand your financial situation is somewhat unstable right now. We'll look carefully to make sure all our recommendations make sense for you.
Now, hearing that, let's make sure that all of our recommendations make sense to you. How do you think that makes the patient feel, Mike, who's got some reservations about the affordability of care?
Fantastic. I mean, you've opened it up for them. You've made it okay for them to say, I don't understand why I need all this. I don't understand why I need this one procedure. I'm not sure I can afford this. You've really given them permission and created kind of a safe environment for them to be able to say something that might be embarrassing to some people, which is, I know I dress really well and I drive a nice car, but I can't afford this right now, even though it's only $1,200 or whatever it might be.
Sure, and once that conversation gets on the table and you can discuss that, even if the patient can't accept care now, what you've done is you've developed a relationship. We're talking about money is good, and so if the patient doesn't take your treatment recommendation now, the patient will stay in the practice, Mike.
Right.
And when they do become ready, they'll choose you as the dentist.
Right.
So by introducing the fit issue you're embroidering it into your treatment plan. You're talking about what's going on inside the mouth. Also, you're talking about what's going on in their life. And we're putting those two together. That's the big difference with what I teach with the Yes Online process. We're going to link what's going on in the mouth to what's going on in the patient's life.
Yeah, because now it's not about that patient was too dumb to get that she needs all this stuff. She got it. She understood it. The fit issue's just not there yet.
Exactly right.
And so when the fit issue or whatever that fit impediment is removed, the relationship has been formed. She's still your patient. She loves you, and she's going to be there to have it done.
Fixed.
It's funny, listening to this doctor talk to this patient, it's so unlike the way I've ever heard any dentist speak. And I've been in a few dentist offices, and it's such a different kind of refreshing way to hear a dentist speak, but it still almost snaps your head back when you hear it because it's not what we're used to in dentistry. He hasn't used the word marginal ridge or curve of Spey. He hasn't talked about a lot of technical things here.
And how did I describe the crown? I said we're going to remove the darkened chipped enamel and replace it with a new enamel-like material.
Right.
I didn't say it was all porcelain crown. I didn't say it was a veneer. I didn't use any jargon at all.
Right.
Okay. All right, let's go on.
Thank you. I appreciate that.
The second area will help you is with the embarrassment you have with your breath. While we're working on your front tooth, we can clear up this infection and get you confident here. It's important that we do this because we don't want that infection to spread to the front teeth and ruin their appearance. Plus, an infection like this can cause bad breath and tooth loss. The way we'd clear up this infection is through a series of special cleanings.
Okay. Now, you notice how I related the benefit of the perio to the chief benefit she's looking for, that is confidence in her appearance.
Right.
Then I went on to make a secondary statement. This is also the culprit for bad breath.
Right.
The procedure, I said, we're going to do this through a series of special cleanings. See, patients understand the word cleaning.
Right.
They don't understand the word scaling and root planing. A series of special cleanings. Again, this is not a consent conversation, Mike.
Right.
This is an influencing conversation.
But it does say it's not a regular cleaning, and it's better than deep cleaning. It's
cleaning.
It's a special cleaning.
It's a special
You're
cleaning.
special. I mean, it makes it sound special. Special might not be good, but
It's not, and you won't lose much time from work from any of this. Now I know you're also concerned about the tooth decay on your upper left side. My suggestion is that while we're working on your front tooth and doing your cleanings, we do your fillings for you. These are tooth-colored fillings and will look very natural.
That sounds good. Can you do all of this at the same time?
Yes, most of it we can. We'll talk about treatment sequence in a minute.
Okay, we'll talk about treatment sequence in a minute. And so it becomes obvious to the patient that this is not the sequence we're doing thing. I'm just discussing it in the relevance to her. And this is one of the toughest barriers that I find, Mike, when I teach this, that dentists and team members really have a hard time getting over how do you talk about treatment unless it's in the sequence of treatment. We learn that way in dental school. It's in all the literature. Oftentimes, the worst sequence to discuss someone's care usually is the sequence of treatment.
Right.
Why? Because those backstage procedures that we need to do, the perio, the endo, the bite adjustments, the bone grafting, all that stuff, that isn't why people come in. They come in for the outcome, the pretty teeth, the confident smile. Those are what I call the sexy procedures. That's what they want to talk about. But it's the unsexy stuff that oftentimes needs to come first. Well, if you front load conversations with all the unsexy procedures you're going to do for a patient, what does that do to the patient's emotional momentum going into your case?
It's just gone. It's wiped out.
It's wiped out, and then they start thinking, well, I don't know, the other doctor said this, and he said that, and you said this. You see, in the app, if the only conversation you can have with a patient, Mike, is about the technical processes, we're going to do this, then we're going to do this, we're going to do this. See, that's a dime a dozen conversation.
Right.
A patient can go to any dentist and hear a process-centered conversation. It doesn't distinguish you as a practitioner.
Right.
What it does, it makes your treatment plans subject to second opinion, and they become price sensitive because you're like everybody else out there.
Right.
But if your conversation can be influencing, and you're talking to the patient about how this dentistry fits into their life, are they going to hear that conversation in another dental office?
No, they won't.
Heck
And
no.
it demonstrates listening. And you're right when you talk about the emotional momentum. I was Christmas shopping for my girlfriend this year, and I found a perfect gift. Well, perfect. I mean, it was like, why didn't I think of that before? And then two little smaller ones.
Yeah.
And I go to order it, and the big one that I really wanted, back ordered. Not shipping until January 13th, after Christmas.
Not good.
Not good. Can't get that. But we can get you the two other ones. Well, what? I don't know. Those were just kind of by the way, and it's like well, we can do these two tooth-colored fillings on you, but number 9, January 13th. It's not going to be there for Christmas, and I didn't make the purchase, and it was demoralizing, and so yeah, I know exactly what you're talking about. I just had it happen to me.
Yeah, ride that horse in the direction of the sun.
That's right.
That's exactly what has happened. Let's finish up watching this video.
The last thing I want to discuss is an area that I know that you're not concerned about. That's the broken fillings on your upper and lower right sides.
Stop it right there. The last thing I want to talk to you about is an area that I know that you're not concerned about.
Right.
See, when you're recommending treatment for a condition that the patient is not concerned about, then preface that recommendation with the truth.
Right.
I'd say, Mike, now the last thing I want to talk to you about is something that I know that you're not worried about. That is the missing teeth here and here. But I want you to know that I am. And when you're ready, I'm going to recommend. And now I'm going to go ahead with my treatment recommendation. But by prefacing my remarks, I know you're not ready for that. What does that do to you as a listener? When I say, Mike, I know you're not ready for this, what does that do to your ability to listen to me?
I know you listen to me, so I'll listen to you and I know that you heard me and you've got my best interest. And not only do you have my best interest, but you get where I'm coming from. Yeah, that's not important to me right now. I need to get this done. Yeah, we will talk about that later, but
yeah. So I satisfied your need to get the front tooth done.
Right.
But what I've also done is I've satisfied the medical legal requirements that I have to sustain as a practitioner. I'm obligated to tell you about this condition. But I can tell you about the condition in a way that you can hear it.
Right.
And when I say, Mike, I know you're not concerned about this, lets you listen to it in a way that's different than if I front load the conversation and say, well, Mike, one of the first things we got to talk about is this.
Right.
And if you're not interested in that, the emotional momentum of the conversation just dies.
Right
on the
That's a
bottom.
great point.
Even though I know you're not concerned, I want you to know that I am, and when you're ready, we'll restore these teeth back to their original shape and size. This is important because back teeth support all the heavy chewing. The front teeth are protected from these heavy forces. This helps prolong their appearance and helps sustain the confidence you want in your front teeth.
I understand that, but they're really not a problem for me now, and I want to get these other problems fixed first.
I hear you. All of my treatment recommendations are really up to you and what best fits into your budget now. I'll make sure that you're comfortable with all your care. Do you have any questions or comments for me?
There we go. So I made the recommendation. I realize this is not important to you now, but I want you to know that it is for me, and when you're ready. And then I linked the benefit.
You did. Yeah, I didn't see that coming.
Right.
Back to the disability.
Right back to the disability. So the Yes Online process starts out in a very simple fashion. And in my experience with this has been excellent. I have a doctor right now who has been using this for about a month. She had a team meeting. She called me. She was so excited. She said, I got to tell you about this. I've been using this, the 4 chiefs, understanding the 4 chiefs, then finding out what the chief disability is, then relating it to all the other areas of her mouth. Her team said, we've been listening to you for, her team has been with her for 4 or 5 years. We've been listening to you for several years now. You speak better to patients now than you ever have. And what's happening is that she's using fewer words. She's spending less time with patients, but her impact is so much greater because she understands now that the basis of almost all dental care is reduction of disability. If you understand what the patient's disability is.
And she may even feel like she's doing a less effective job talking to patients because she's not using all the technical jargon that we've been using for decades. But meanwhile, the independent observers, the 4 staff members in there who are totally objective when they view these conversations, say, you have never been better. And she might say, I feel like I don't feel like I'm doing anything, but it's working. And that's the result, is that patients are getting the care that they're interested in.
Communication is a funny thing. Mike, you and I are both speakers on a national level. There's been times where I thought, wow, I was just not on today. And then I'll have 20 audience members come up and say, wow, this was really good. And there's other times where I thought I really hit it, and maybe the critiques don't come back so great.
Right.
It's hard to evaluate ourselves.
Right.
And the ultimate judge of whether we're being interesting or influential really is in the listener.
Right.
And so much of what we do is, are we interesting when we present care? And when we use jargon, when we use technology, when we talk about Angles classification and curvus spi or anterior guidance, all those words feel good to us, but they're simply not interesting to the patient.
Right.
And in the absence of interest, there's an absence of influence. So one of the prime requisites that I teach in Yes Online is how to present in an interesting way. Because just because you're an expert doesn't make you interesting.
Right.
And in the absence of that, people don't hear you.
The goal is not to impress patients with how smart you are. I don't think they'd be sitting in your office in the first place if you were smart, but to get real, to be authentic about it and to hear what they say about what's bothering them about whatever condition it may be in their mouth, and to take their current financial situation into mind when you do this, and then to present the treatment to them in the way that's emotionally fulfilling to them, because it's the things that matter to them most, and then sequence it and explain why you're doing it that way. I mean, it just sounds like a fantastic, a real, authentic conversation to have with people, instead of trying to impress them with, let me give you 5 minutes of why I'm really smart when it comes to fixing these problems, and then have them go, oh, I had no idea you were this incredible. I thought that this was just a sideline job for you and you're actually a janitor. But now you've impressed on me that you actually are a dentist. Go ahead, have at it. It's just such a great way to be able to relate to people, and that whole conversation that we just watched was in plain English. I mean, there really was nothing there that was confusing, and because of that, it does seem like any staff member could have that conversation if the dentist doesn't want to do it. But I can see why it'd be so valuable for the dentist to build that relationship with the patient, since we're going to be the ones with the hands-on, with the needles and the drills and everything else. Why not be the one who has that relationship with the patient?
The tool creates the opportunity for delegation.
Right.
Because in the presence of a tool, now you've got a process that you can go back to. And so much of this, Mike, is learning to speak the language of the patient. The language, here's what patients understand. I'm going to get my teeth fixed when I'm ready, by people whom I'm comfortable with, and when I can afford it. Patients understand that. That's the silo. That's the domain their head is in. Why not go there with them? Years ago when my daughter was little, she would ride dressage. Dressage is where you sit on a horse and the horse makes all these movements, and I'm watching Kristen, my daughter, doing it. I said, Kristen, how do you train a horse? And she said something very interesting to me. She said, you don't train the horse, you train the rider. You see, here's the rider's dressage IQ. Here's the horse's dressage IQ, right?
Right.
And what are you going to do? Raise the horse's dressage IQ? Like show it a videotape or teach it to speak English, right? Right? Well, no. What you do is you learn to speak horse. That is, you learn to speak the language of the horse. A thigh pressure means the horse is going to move away from pressure. That's how you communicate with a horse. Well, here's your patient's dental IQ.
Right.
Here's yours. And what do we do in the culture of dentistry, Mike? We try to raise the horse. Raise the dental IQ. Raise the dental IQ. That's the holy grail of dentistry. Educate, educate, educate. Well, does education actually work?
Well, if you can get the patient to commit to 4 years of dental school,
Right.
And then
Right.
practice for a few years. Yeah, I think they'll be smart enough to actually make those treatment decisions. But otherwise, no, it's too confusing. It's a crash course in dentistry in 4 minutes when they're sitting there kind of stressed out anyway because they have no idea how much this is all going to cost and whether or not this fits.
That's the thought that's going on ahead. And
Right.
I'm not against patient education. I'm just saying that if you're here, if the patient's here and you're here, it's far easier. It's far more influential. Hear that word. It's far more influential if you come down to the level of the patient, that is, speak the patient's language. And what Yes Online is, Mike, it's the tool to make that happen. I've laid it all out. There's 8 modules. It will take a dentist and his team about, if they work at one module a week, each module takes about an hour to go through. There's about 15 minutes of video, and then the rest is discussion and actually application in the dentist practice.
So the staff watches it together, the dentist and the staff members?
The dentist and staff watch that video. That video is an example of 8 other videos that I have just like it, okay, where there's actually a case study that you work through.
That's pretty good because now the staff knows what the doctor's supposed to be doing while the doctor's in the room as well.
Exactly.
They can hold them accountable.
So if the doctor starts doing this yak, 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 the team member can,
Well, that's why dentists should sit on chairs with wheels, so the staff member can just
pull
grab
them
onto it and
out.
pull them out and say, well, give
push
them a little
them out
pep
the
talk and
back
then put it
door.
back in. Hold on while we reprogram the doctor.
That's so true. So a dentist and his team could spend an hour a week, and in about 2 months, they would have the whole system done. And what's nice about Yes Online, it's documented. You've got the manuals. You've got it on DVD. You can even put it on, what do I do with my cell phone? What you can do with this, I've got a little iPhone right here. You can take the module and actually put it on. I'm working through this process now to where we can put the video on a little handheld device like this. Now, this is me teaching one of the modules. Now, what if you walk in, you're about to walk in to do a case presentation, maybe you're a young dentist, maybe you're a little nervous about it. All you got to do is, what did Homoly say about this? Pull your smartphone out, watch it for 2 minutes, just-in-time learning, put it down. You've got the Discovery Guide as a tool. You walk in and you do it. And
That's fantastic.
The point of having the tool, again, Mike, is to change the behavior. If you have the tools, if you got the documents, if you've got the videos, now you've got a process that you can go back to, and you've got a process that you can lead. And that's really the strongest benefit of Yes Online, is that it's documented, it's duplicatable, and it will outlive any changes that you have in your team.
Wow, that's great. Yeah, because like you said, we employ a lot of women. It's what happens, and they go out on pregnancy leave, and other things happen, or a husband, they get married, husband has to move away in the service, or something like that. So it does need to be systems dependent, not people dependent. So that makes a lot of sense. So, how do dentists find out about this? They go to your website.
Go to my website. It's my name, paulhomoly.com.
Homoly.
That's right, Paul.
Okay.
It's paulhomoly.com. paulhomoly.com. My homepage will come up. Look for Yes Online. It's right on the top. And just click through to it, and you can enroll online. All of the forms and all of the manuals are available online. You print out the PDFs. You can take it to a local printer. You can have it nice. The manual is well done. It's done in color. You have these printed up and binded. And it's nice having a nice manual because it says to the team, we're serious about this.
Right.
This is not some cheap photocopy of some notes I got at a lecture. This is a manual.
Right.
And then the dentist or team member would lead that. What's available, everything that's available online is duplicatable on the DVDs.
Okay.
So if you don't have high-speed internet access. What's nice about the internet is that when you're done with the module and you've got a question, I have a little discussion group. You can type in the questions. I check it once a week. And if you say, hey, I don't understand this, hit the button. My team checks it, they alert me, and I send you back an answer.
You get an answer back. That's a great idea. You know, I've heard from meeting planners recently for some of the lectures I've been doing that doctors traveling a distance to seminars is down a little bit, you know, because of the economy, and they realize how expensive it is to take a day out of the office, you know, travel somewhere, get a hotel for them and their staff and things like that. This, I think, represents a great value proposition for being able to learn this type of skill without having to take all that time away out of the office and go somewhere to see you.
Well, I had this 30-something dentist come up to me, and I was showing him Yes Online. He said, well, good, I'm glad you're doing this. He says, I do a lot of training online. He said, I think going to seminars is so old school. Now, I like the live seminar.
Right.
Because I think there's some collegiality and some energy that exists there. But, when you think about it, with the increased speeds in broadband, with the increased accessibility of video on smartphones and DVDs, it's crazy for us not to leverage the technology.
Right.
So a big part of my career for the next 10 years is going to be documenting and putting together interactive programs available on DVD and online. You at Glidewell have done a terrific job, Mike. I was looking at your work earlier, and I think it's the best in the industry, Mike.
Thank you.
I've seen a lot of people's videotapes on technology, and there's all sorts of websites up right now that show, different processes. But what I like about what you do is that you get beyond the information. You get into the little things that oftentimes, if you don't know this little thing, it really changes the outcome.
It does, and you just can't assume that everybody knows that that little thing, even though it seems like very basic knowledge to you.
Right.
I get bored showing some of the stuff because I've shown it so many times, and then somebody will say, well, that was really cool. I'm glad you showed that, and I'm glad I learned that. And for other people, it's not necessarily boring. It just reinforces what it knows. But I love your stuff. I love the fact that you're willing to talk about something that I think is vitally important to dentists. And that's the money issues, the uncomfortable money issues,
Sure.
Around dentistry, case presentation, actually getting paid for it. These are the things that I think go a long way towards determining what a dentist's satisfaction is going to be, not just with a Monday or a month or a year, but the career when they look back on it and how fulfilling this was. And that's why I think this is so important. If you're going to dedicate your life to this profession, when it's all said and done, you want to have something to show for it and really felt like, I gave a lot. My back's killing me. I might have a little carpal tunnel, but I've done well, and I've set my family up well, and I served thousands of patients well for all those years, and I feel pretty good about the contribution I made on this planet. So thank you so much, as always, for coming here and spending some time with us. I appreciate it. Well, that about wraps it up for this edition of Chairside Live. My thanks once again to Dr. Paul Homoly for being so generous with his time. And so on behalf of everybody here at the lab, the CSL crew, and myself, I want to thank you for your time and your continued commitment to quality dentistry. Mahalo.